I will introduce the next speaker, who is Dr. Ziyad Al-Aly. He is a physician scientist and serves as the Chief of Research and Development Services at the VA St. Louis Healthcare System. And he will talk about an overview of long COVID. Over to you, Dr. Al-Aly. Thank you so much in advance.
Thank you guys for having me. So really delighted to be with you guys. Thank you again for having me. This is a delight. And really, I noticed that there's so many people on the panel that I admire so hugely, including really a wonderful Nelly Brusaleris from KI on the panel. So, and this afternoon, Ambassador Briggs. So really delight to be with this really cadre of people who have been my heroes for a long time. So thank you for the invitation, Kevin, and thank you for the introduction. So I'd like to talk to you today about long COVID and provide really a brief overview of our thinking about long COVID and some of the data from our team. In terms of disclosures, consulted for Gilead and Tonics regarding COVID, and the opinions expressed in this presentation do not represent the views of the U.S. Department of Veterans Affairs or the U.S. government, which is my formal employer. And the funding that we got to do most of this work is actually also from the U.S. Department of Veterans Affairs and from the American Society of Nephrology. So in terms of outline, what I'd like to talk to you today is that the story that led us, is a group of clinical epidemiologists here in the Midwest in St. Louis to really devote, a lot of bandwidth from our group to study long COVID. Give you a bit of broad overview of long COVID and discuss the long-term manifestations or long-term consequences of long COVID, including cardiovascular outcomes, kidney outcomes, diabetes, and mental health disorders. Talk a little bit briefly about our thinking about the effect of vaccination on long COVID outcomes, and then discuss implications for health systems and communities, and then put it all in a summary slide. So very early on in the pandemic, I do recall this like in March 2020, when sort of all hell is breaking loose and all of a sudden our lives here were upside down. It was really very stressful time. We went on lockdown. We all sort of left our normal workplaces. We started working from home. And we as a research group in St. Louis started pondering like, what the hell is going on? And then how do we as a group of researchers and physician scientists do our part to really help address the challenges of the pandemic? Some of us are physicians, including myself, and we could go to the front line and work in the ICUs and help patients, and we did that. But also a bunch of us are like, purely clinical epidemiologists. So we started deliberating, like, what's the best way to really contribute to the fight against COVID-19? And the answer was very clear. We pivot. We've been doing and some of you on the call actually will know that we've been working on pharmacoepidemiology and environmental epi, but then we shifted focus to really studying COVID-19. And then we started getting reports from patients. And I consider this really the index case for what we now call long COVID. And didn't come in a case report in the Journal of Medicine, did not come in a case report in the BMJ or anywhere else. It came in the form of an op-ed piece in the New York Times by the amazing Fiona Lowenstein, who basically said to us, you guys were all telling in April of 2020, in April, like really shortly after the beginning of the pandemic, in April 2020, she basically was saying that you guys all tell us that SARS-CoV-2 is a mild virus in the young people, in the young population. And you get the infection in a week or two or three, you get over the infection and you're back to baseline and you feel fine. Guess what? That's not my experience. So let's talk about what coronavirus recoveries look like. They're not recoveries at all. And that op-ed piece really ignited a wonderful reaction from patients like her, who, to their credit, coalesced around each other's and then started forming this patient movement and coined the term long COVID. And really one of the most remarkable sort of stories of the pandemic is this particular group that sort of came together out of nowhere, and formed what we now call the Patient-Led Research Collaborative. And they published an analysis very early on in the pandemic in May 2020, a survey, an uncontrolled survey. There was no control group, an uncontrolled survey sort of detailing, cataloging the breadth of organ or the breadth of symptomatology that these people, most of them are really young people that got COVID-19 in March or early March 2020. And here they are in May 2020, 2 months later, still with persistent cough, fatigue, brain fog, muscle pain, and lots of other manifestations. And to their credit, again, and this is really very, very important, they coined the term long COVID and they started referring to themselves as long haulers. So I really think this is a historic moment in the history of medicine, in the annals of medicine, that patients came to the fore, alerted all of us scientists that something here is wrong, needs to be investigated, needs to be researched, and really gave the disease, gave the entity its name. And this is absolutely, absolutely remarkable. And I consider this is really a historic moment in the overall pandemics. So we looked at that report, and it was an uncontrolled experiment. It was an uncontrolled analysis. It was a survey of their membership. There was no control group. And so we decided to sort of think, we were thinking deeply about it. It's like, we asked the question, what is long COVID? What is it like? Really, it's really genuinely, if we were to, do those, do sort of a, carefully controlled analysis, what is long COVID? What are the true manifestations of long COVID? And at that time, really, there was not a whole lot of science about it at all. So we decided to take we call it an unbiased approach, a systematic approach or systematic characterization to really gain a deeper understanding of what long COVID is. And this is really our early work here, where we did a high-dimensional characterization of the post-acute sequelae of SARS-CoV-2 or COVID-19. And what we found, that was very early on in the pandemic, that people with SARS-CoV-2 infection who survived the first 30 days, these are survivors, the virus did not kill them in the very first 30 days, went on to develop a variety of problems, including increased risk of mental health disorders, nervous system disorders, metabolic manifestations, including new onset diabetes, GI problems, skin disorders, rash and hair loss. Really, coagulation problems, were noted even very early on in the form of blood clots. And then now I'll revisit this because it became a central hypothesis into the pathogenesis of long COVID. Cardiovascular conditions, respiratory problems in the form of persistent cough and shortness of breath, et cetera, kidney problems, musculoskeletal disorders, and malaise and fatigue and anemia. And if you can appreciate it, you can look at this. There's almost universally, in the long phase or in the post-acute phase of the disease, SARS-CoV-2 can affect nearly every organ system. So this is really not a respiratory virus. It's really a systemic virus. It's a systemic illness that can affect nearly every organ system. And then we sort of deliberated about this a little bit more, and we said, we know that a lot of people, at least prior to the pandemic, had gotten seasonal flu. That's another well-characterized respiratory viral infection. So we wanted to do an analysis to compare the outcomes, the post-acute outcome in people with SARS-CoV-2 infection who survived the first 30 days to people with seasonal influenza who also survived the first 30 days of infection. So what we found is really two distinguishing characteristics when we compare COVID versus seasonal influenza. One is that the magnitude of risk is much higher. So really, COVID is not the flu in the acute phase, and COVID is not the flu in the post-acute phase. Absolutely not the flu. The magnitude of risk was consistently higher with COVID than what we see with seasonal influenza. And number two, and this is really a very important distinguishing characteristic, is that the breadth of organ involvement, the breadth of organ that it touches, that it could potentially produce sequelae in, is much more extensive than seasonal influenza. And these are really two key distinguishing characteristics in sort of thinking in those comparative evaluation studies about COVID versus flu. So we really simply concluded that it's really a different kind of post-viral syndrome. This doesn't really resemble the post-flu in these two really key features. And then we wanted to sort of really gain a deeper understanding whether the magnitude or the risk of post-acute sequelae, it really increases with the severity of the infection. And really the very good proxy, really an amazing and wonderful proxy for the severity of infection, people really needed to be in the hospital for it, or even who needed to be in the ICU for the acute infection, right? The people who nursed it at home, who may have gotten COVID-19 and nursed it at home versus hospitalized versus people in the ICU. What we found really a couple of really interesting observations is one, that the risk was evident even among those people who nursed it at home and did not need to be hospitalized. So this is really, and this is really very important because the lion's share, the majority of people with COVID-19 don't ever get hospitalized. Most people get COVID-19 at home, nurses for a few days or a week or two, and they think they got over it, and then they get like all these, they continue to have lingering fatigue and brain fog and et cetera, et cetera. These are non-hospitalized people with COVID-19. However, we also found that the risk increases in a graded fashion according to the severity of the infection. And I think this is really also quite important because, people who were hospitalized for the condition in the acute phase exhibit a much higher risk of post-acute manifestations. And the risk was highest in those people who needed ICU care, on a ventilator, et cetera, et cetera. So those people tend to do worse. But again, one key thing here I want you to remember is that the risk is evident even among non-hospitalized. And why this is really important? Because this is really the majority of people worldwide who get SARS-CoV-2 don't get ever hospitalized for it. So the risk of long COVID is evident even in that group. And then we wanted to sort of try to understand, unpack these sequelae of SARS-CoV-2 and try to sort of see if some sequelae are expressed more heavily in older adults or younger adults or by sex and comorbid condition or baseline health status. And if you look at the slide and say, oh my God, Ziyad, you're showing us this and it's all over the place. You got the right conclusion. It's all over the place. So I think one of the major conclusions I want to take from this slide that A, long COVID is a multifaceted disease. That two, that it's really the different sequelae behave in different ways in different racial groups, sex groups, age groups, and according to baseline health status. So if you want to conclude one word here, long COVID is non-monolithic, is not a monolithic entity. It's not all one thing. Now we lump it under this broad umbrella term and we call it long COVID. But long COVID is not one thing, it's multiple sequelae. And it's really a non-monolithic disease. These different sequelae behave in different ways in different individuals according to age, sex, race, and baseline health status. So one word here, non-monolithic. Long COVID is non-monolithic, is not one thing, is absolutely not one thing, doesn't all behave in one direction. So when we did all of these things, we started sort of thinking about, okay, well, what are sort of the things that really are concerning us here? Really, went back to the drawing boards, like, okay, what are really the alarming findings from the work so far? And really what we could tell at that point is we were really concerned about cardiovascular disorders because some of them are really chronic conditions that will literally stick with people for a lifetime. And we were concerned about new onset diabetes, we're concerned about kidney disease, and neurologic and mental health disorders. And again, because some of these conditions are really not transient or temporary or conditions that can go away in a week or two or a month or two or three. Some of these conditions could really impact life expectancy, could really stick with people for a lifetime, and may have broad and significant manifestation or significant consequences for health, et cetera, et cetera. So we decided first to focus a little bit or to take a little bit of closer look or do a deep dive into the cardiovascular manifestations of long COVID. This is really, again, the cohort of about 150,000 people with SARS-CoV-2 compared to two major control groups. One control group, about 5.5 million people who lived during the same time period as those with SARS-CoV-2, but did not get COVID-19. And another control group of about 5.5 million people who had no COVID-19 and lived in an era that predated the pandemic. So these are totally removed from the influence of the pandemic and all the mayhem that ensued when the pandemic started, globally and hit us here hard in the US. So what we found is that, people with SARS-CoV-2, when we found them for at least a year here, they had an increased risk of post-acute sequelae in the, in terms of cerebrovascular disorders that included strokes and TIAs, transient ischemic attacks. Those are mini strokes, increased risk of dysrhythmias or included atrial fibrillation, atrial flutter, et cetera, in inflammatory heart disease that include pericarditis and myocarditis, ischemic heart disease, and thrombotic disorders, and heart failure. If you notice also one thing here, there's really not one specific entity, like, oh, it's like only like atrial fibrillation or only like blood clots or only strokes or inflammation in the brain or strokes. But really sort of broad net of manifestation that could occur in the post-acute of SARS-CoV-2. And then here we looked at kidney outcomes in people with long COVID. Those are also followed for a year to sort of characterize the risk of post-acute AKI, end-stage kidney disease, and a composite endpoint we call MAKE, M-A-K-E, or major adverse kidney events, which is sort of an end-stage kidney disease or death. So what we found here, we found that people with SARS-CoV-2 compared to, again, a bunch of controls, both contemporary control, people who lived during the same time period as those with SARS-CoV-2 infection, and a historical control group of people who lived in an era that predated the pandemic. So compared to people unaffected by the pandemic and compared to people who did not have any SARS-CoV-2 at all, what we saw that people with SARS-CoV-2 had significantly increased risk of these kidney problems. If you can pay attention a little bit to the trajectory here, it's really wonderful to sort of see this sort of like a really a revelation over time. We characterize the risk here, or the risk of decline, in what we call GFR or eGFR. It's a marker of kidney function. It's a sort of quantitative marker of kidney function. What we saw that even among non-hospitalized individuals, even among people who were not hospitalized for the condition in the acute phase, they went on to experience a decline in kidney function over the ensuing years. And the magnitude of decline here is between 2 and 4 milliliter per minute for that year. And if you want to conceptualize it, that's really the equivalent of aging 2 to 4 years in the span of just one. So you can think about it that even in mild cases, even in the cases that did not require hospitalization, being hit with COVID is almost tantamount. It is tantamount to accelerated aging in the form of really it pushes you forward in time. It ages you. In the span of that 1 year, you're aged almost 3 to 4 years. So, and that's really remarkable, because you're almost losing time on this earth just by getting that SARS-CoV-2, or your kidney losing time on this earth just by the mere fact that you got that infection. And then the risk is more profoundly present or evident in those who were hospitalized and those who needed ICU care. And then here a bit of data from our team as well, really the amazing Yan Shea and my team, who wanted to do really a deep characterization of the risk of diabetes in the post-acute phase of SARS-CoV-2. We saw very early on in the pandemic that SARS-CoV-2 could provoke derangement or sort of a lot of different sequelae, metabolic sequelae. So here we wanted to focus on new onset diabetes. And what we found, or what amazing Yan Shea from my team, found here, was an increased risk of new onset diabetes in the post-acute phase of the disease. Again, what's really very, very important here is to show that the risk was evident even among non-hospitalized. People sort of try to associate it as, people have severe disease who get an ICU, but I didn't get an ICU, I didn't get hospitalized, I had mild or even asymptomatic disease. Even in that realm, there was a significantly increased risk of diabetes, and the risk was increased progressively in a graded fashion according to severity of acute infection. And mind you, here we looked at the anti-hypoglycemic use, meaning that this is not only diagnoses with diabetes, the hemoglobin A1C. Somebody thought it was actually sufficiently severe or advanced enough to really initiate anti-hypoglycemic medication. And the picture was very consistent. And then we wanted to sort of unpack a little bit the mental health disorders in people with SARS-CoV-2. And we started with the premise that all of us at least in the US, I realize there's a lot of international audience on the team, but in the US, we were under enormous distress. So all of us here, we were really under enormous distress. But we asked the question, do people with SARS-CoV-2 infection have it worse? Simply, all of us endured a lot of pain and mayhem and distress in this pandemic. Sort of things are all of a sudden lockdowns, grief, we couldn't visit family, couldn't go to the gym, couldn't go to, all of a sudden our lives were changed overnight. Literally overnight. The streets were empty and things were that created enormous amount of stress here in the US for all of us. So we asked, do people who got SARS-CoV-2 infection have it worse? And the answer is absolutely yes. People with SARS-CoV-2 infection manifested with increased risk of anxiety disorders, depressive disorders, stress and adjustment disorders. And those are not only diagnoses, those were diagnoses that coupled with the initiation of antidepressants, initiation of benzodiazepines, and other medications, other neuropsychiatric medications. Well, we also found that people with SARS-CoV-2 had an increased risk of opioid utilization, substance use disorders, neurocognitive decline, and sleep disorders. So put together, we entered this pandemic as a nation in distress. The pandemic put us in even more distress, all of us. The people with SARS-CoV-2 specifically went on to manifest a much higher burden, a much higher risk and burden of these psychiatric or mental health disorders. And I think this is really important because we really very seriously think about this a lot. And we think it really demands attention now to nip it in the bud or try to sort of address it now before it cascades down to a much more serious problem. If you notice some of the outcomes that I showed you, increased risk of anxiety, depression, but then also opioid use, also substance use disorders, sleep problems. That's really a toxic mix that could cascade down to become really a suicide epidemic in the next year or two if this is really not addressed really urgently, here in the US. And we've made a lot of progress in curbing opioid utilization in the US prior to the pandemic. We see early signals in the data of reversal of that improvement, of going in the wrong direction. And we think that's really demands serious attention now to help address it and mitigate further downstream, even more serious and more grave consequences. And you'd be asking me now, well, okay, well, a lot of this data you showed it from the early phase of the pandemic before we didn't have vaccines and et cetera, et cetera, et cetera. So what's sort of the effect of vaccines on long COVID? So, if you read 10 studies, it come up with 10 different results. And I think our studies suggest that vaccines reduce but do not eliminate the risk of long COVID. Overall, the risk reduction that we see in our population is about really 15%, 1.5. And that's not very high. It's definitely doing something and definitely contributing to risk reduction, but it's certainly not sort of a panacea or sort of the tool that can really totally abrogate or totally eliminate the risk of long COVID. And I have to mention here that other studies sort of found a much more profound, a much more like higher risk reduction. And I think the heterogeneity in these studies and how we define long COVID, we have sort of very sort of a sophisticated way here. I'd like to think in sort of thinking about long COVID and defining long COVID and assessing risk very meticulously. Our analysis suggests a risk reduction of 15%. Others are a little bit higher, but it's really in the way you define long COVID. And if you look at an elephant and a small dog, and you say, oh, well, like they're different in size. Well, yeah, because you're looking at two different things. You're not going to accept, you shouldn't expect the same magnitude when you're measuring two different things. So I think some of the heterogeneity in the studies will really go back to the fundamentals of how to really measure a disease and measure outcomes related to long COVID. So one of the things I'd like to touch upon here is really, so what's driving all of this? What are sort of mechanisms of long COVID? And this is really a wonderful review by Murad and Iwasaki in Science in 2022, where they sort of like broadly discuss the putative mechanisms of long COVID. 4 major hypotheses have been proposed. One of them is really autoimmunity. The immune system was revved up during the acute phase of the infection and then turned onto self. Number 2 is microbiome dysbiosis. So the idea that the microbiome within us or on us as well gets disturbed with SARS-CoV-2 infection, and then it sort of manifests in derangement or in post-acute sequela. The third hypothesis is that of tissue damage and then sort of like maladaptive repair, et cetera, that might produce post-acute sequela in the heart and the kidneys and the lung and the pancreas, et cetera, et cetera, et cetera. Fourth, and really, I think a leading hypothesis is that of the persistence of the virus in immune privileged sites. That some people, and that's not everyone, but in some people, they do not clear the virus immediately and clear it fully. And the virus, either as a whole or fragments of the virus, like small RNA fragments, small fragments of the virus or viral proteins, they remain or persist in quote immune privileged sites. And then that may go on to provoke inflammation, et cetera, and then provoking or resulting in post-acute sequela of SARS-CoV-2. When we talk about long COVID, I really want us to think about it as an umbrella term. Long COVID is not one thing. I sort of showed you data from our group to suggest that it's not a monolithic entity. It's absolutely not one thing. And it's helpful to think about it as an umbrella term. And it's also helpful to think that a lot of the manifestations of long COVID, they do overlap with post-hospitalization syndrome or post-ICU syndrome. Obviously, for people who were hospitalized or went in the ICU. And then more broadly, the post-infectious illness or the post-viral illness isn't really anything new. People get surprised, oh my God, long COVID after SARS-CoV-2. But the idea of a post-viral illness is not really new, is that we as a society, we as a humanity decided to sweep it under the rug and not investigate it for 100 years. We decided to ignore it for 100 years, and it's coming back to bite us now in the rear end. But the idea of a post-flu Or when the flu pandemic happened in the very early decades of the 20th century, there were a lot of people who manifested with post-acute disease. And at that time, they called it encephalitis lethargica or sleepy sickness or post-encephalitic Parkinsonism. Not really new at all. It's at least 100 years old, if not more. There is measles could also produce post-acute manifestations in the form of subacute sclerosing panencephalitis. We now know that EBV or Epstein-Barr virus can lead to multiple sclerosis decades later. We also know about the post-Ebola syndrome, post-polio syndrome. Again, and this is really a small list of it could be much, much, much larger if we wanted to be comprehensive. But really to give you a glimpse here that the post-infectious condition or the post-viral condition is absolutely nothing new. It is we decided to ignore it in medical curricula, ignore it in research, ignore it in funding for more than 100 years. And then, there is quite a bit of overlap and similarity, but some distinctions between SARS-CoV-2 or post-acute sequela of SARS-CoV-2 or long COVID and MECFS or chronic fatigue syndrome. So I asked, so what's the burden of long COVID in the general population? We put it anywhere between 4 and 7%. You read a lot of different studies and they put it much, much higher. They have a double-digit sort of burden. We think it's anywhere between 4 and 7%. And we think it's really a very, very, very important crisis. So when you're putting a single-digit percent, 4 to 7% in our data and our analyses, we're not minimizing it. That's still a huge toll. And we think it's really a major health crisis. It's not rare, a major health crisis. This is, again, another op-ed piece on the first anniversary of their op-ed piece in New York Times, again by Fiona Lowenstein and now Hannah Davis, talking about long COVID and saying that it's really not rare, it's a health crisis and demands attention now. We cannot agree more. We cannot agree more. So what are the implications for the health system? The burden of long COVID is likely substantial. 4 to 7% of people infected with COVID-19 is not small, is absolutely not small. Long COVID is a multifaceted disease that can affect nearly every organ system. We see this early data from the GBD and IHME. There's really resulting in some increase in the burden of cardiovascular disease, diabetes, kidney disease worldwide. And based on our work, IHME projects some increase in numbers. But so to give you a bit of a glimpse that this will contribute to a rise in the burden of non-communicable disease in the US and elsewhere. So we think it's very, very important that governments and health systems prepare for the people in need of post-COVID care. UK National Health Service has done a good job so far setting up post-COVID clinics. There's several other health systems in the US are doing the same. We at the VA have a wonderful network of clinics nationwide to address the care needs of people with long COVID. So what are the implications for communities? So the best way to prevent long COVID is prevent COVID through vaccination. I mean, that's really very important, to prevent the infection in the very first place and get vaccinated. And I think that is really a very important role here for misinformation and disinformation, gaslighting management. And that really requires active management. We see a lot of misinformation, a lot of disinformation, a lot of gaslighting in this pandemic. And I think we as medical professionals, we as public health people, we as people who are responsible to really communicate the truth to our societies and our communities, it's very important that we take an active role in combating and really rebutting misinformation, disinformation, and gaslighting. And I think that's really very, very important. And if there is really one silver lining in this whole thing, is really the power of patient advocacy. And they are absolutely, absolutely, absolutely amazing. They are the people who alerted us that long COVID exists. They are the people who actually gave it its name. It wasn't us, it wasn't the VA, it wasn't NIH, it wasn't the CDC, it wasn't somebody in the UK or ONS or anywhere else. It was them. It was the patient community who did that. And I'd like to also draw attention, when you think about COVID, most people think about cases, hospitalization, and sort of acute parameters or things on your dashboard that are easy to retrieve. Oh, this is the number of people tested positive. This is the number of hospitalization. This is the number of deaths from COVID in the acute phase. But I want you to sort of think that you're only looking, guys, at the tip of the iceberg. You're only looking at the tip of the iceberg. Below that tip, it's much, much harder to see, is really the long-term manifestations of long COVID or long-term manifestations of SARS-CoV-2 infection in the form of disease and disability, its potential effect on life expectancy. We worry about kids and we worry about young adults and people in universities and colleges and what that might do, that brain fog, that sort of cognitive decline or cognitive impairment, what that might do to their ability to develop, to continue to develop, and also educational attainment. There are some early indications of really serious serious economic implications, so labor participation, economic productivity, and healthcare cost. And obviously, societal implication is really profound. People who have long COVID, it also affects their families, their relationships, their caregivers, their friendships, and it really has wide-reaching ramifications. And because of the scale of this, because this is not really to two people, these are millions of people in the US and many, many, many more around the world, we think it will have profound consequences. And again, the other major component is some of the manifestations of long COVID are really chronic conditions that will last a lifetime. So these consequences will reverberate with us for decades to come. So in summary, I hope it's sort of communicated to you that long COVID is not one thing. It's a multifaceted, non-monolithic disease that can affect nearly every organ system. We estimate, our group estimates the burden anywhere between 4 and 7%. We worry that some of the long COVID manifestations are chronic conditions that last a lifetime. We really urge governments and health systems to develop and adapt quickly to this and develop post-acute care strategies. That's very, 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 very important. There are a lot of people to mention on the slide. A lot of people sort of led us to where we are right now. But really, really enormously grateful to the core team, including the amazing Yang Shea, Benjamin Bo, the absolutely amazing Evan Shu, other members from our team, Miao Kai, Andrew Gibson, Taeyang Choi, John Sicante, and Uli Lebelis. Grateful to the funding from the U.S. Department of Veterans Affairs, the American Society of Nephrology, and really the strong admin support that we get here in our office from Research and Development Service and the Public Affairs at Washington University in St. Louis. And I would be amazed, it's really important, and most importantly here, really to sort of recognize the long haulers who inspired us and continue to inspire us to do this. It's actually very, very reasonable for me to say, I would not be talking to you. I would not be doing this research. We would not be doing any of this had it not been for their inspiration and their support. So really, the credit is to the long haulers, to the community of patients who are supporting us from the beginning, inspired us to do this, and really the amazing journey so far. So thank you all, and be happy to do the Q&A.